Right. I think that I told y'all that I really, really like the key points in the back of the chapters, and I like to kind of use those as an outline when I explain things to y'all. So I'm going to read those out first, and I'm going to kind of just talk to you guys and summarize this, and then we'll go through the PowerPoints, okay? So if you want to follow along I'm on page 439. Heart failure is also known as congestive heart failure, and it's a condition in which the heart cannot pump enough blood to meet the tissue needs of the body. So remember I told you guys, basically the circulatory system is overloaded and the heart is not strong enough to send that blood where it needs to go. So it kind of backs things up. Left-sided heart failure specifically leads to pulmonary symptoms such as shortness of breath and a moist cough. Left-sided heart failure does. Right-sided heart failure can be seen with fluid backup in the body, such as distended neck veins, that jugular vein distension, peripheral edema, and hepatic engorgement. So heart failure, the heart essentially is not strong enough, or the circulatory system is too overwhelmed for the heart to be efficient and pump blood where it needs to go, okay? So the next category that we're talking about are cardiotonic drugs. Cardiotonics increase the efficiency and improve the contraction of the heart muscle. So rather than affecting they're actually making the heart squeeze and pump harder. Does that make sense? Like it's making that beat more forceful. So instead of the heart working hard and beating, it's just squeezing harder and pushing harder. So they increase the efficiency and improve contraction. But they have a very high risk for toxicity. Remember at the very beginning, we talked about our therapeutic levels, and we talked about that therapeutic range. And if they had a wide therapeutic range, then they didn't have a really big risk for toxicity because they worked from this point to this point. But if they had a real narrow therapeutic index, they had to be right in between there to work. And if they were below that therapeutic index, then they were not effective. And then if they were above, then they were toxic. So cardiotonic drugs are a drug class that is very much that way. So because of this, because of their toxic effects, ACE inhibitors and other antihypertensive drugs are usually gone to first. They're not, they used to be the number one, like everybody used to take these drugs, and then they found safer alternatives. So because you need to know that they have a very narrow therapeutic range and a high risk for toxicity. When a cardiotonic is used, the pulse rate is monitored and the drug is held if the patient's heart rate is less than 60. And with these medications, the heart rate is being slowed because it's being more forceful. So it's slowing it down and it's pumping it harder. And so instead of like 100 crappy beats, you got 60 good, strong beats. That's what cardiotonics do. Does that make sense? So they're actually affecting the efficiency of the heart. So you have to monitor the pulse rate. Adverse reactions are typically GI in nature, but a lot of drugs are GI in nature. So the reason that's a problem is because patients are often at a toxic range before anybody realizes that they're in a toxic range. Does that make sense? Because a lot of meds cause GI upset. You know, a lot of meds cause problems like that. So these medications, there's not a lot of them. That's why I decided I wanted to move on to this chapter. Y'all see the little box on page 439? That's it. That's all of them. The most common drug in this drug class is digoxin. Because that drug has a narrow therapeutic level, a narrow therapeutic range, we take levels of that drug. We draw digoxin levels. There's actually a blood test to tell us what their levels are. Signs of DIG toxicity can be found on page 438. They are GI issues like anorexia, nausea, vomiting, diarrhea. That leads to weakness and lethargy, headache, drowsiness, and blurred vision. And then leads to the cardiac problems, changes in pulse rate, EKG changes, and PVCs. That normal DIG level is found on page 437, and it's 0.8 to 2. And DIG has a lot of drug-drug interactions. So y'all see how we're learning as drugs are created, we're learning to go with the safe. Remember I said the benefit risk? So when there were no other drugs out there and your heart wasn't pumping efficiently, then this was the go-to drug, and it was worth it to risk all those drug-drug interactions, and it was worth it to risk toxicity and all that other stuff. But now that newer drugs have been introduced, it makes a little more sense to start with those other drug classes. Does that make sense? If a patient has been taking DIG for 20 years, that patient's usually going to stay on DIG. If it's not broken, we're not trying to fix it. But when they're initially prescribed, they're going to go for some of those other treatment options. So basically, that's chapter 38 in a nutshell. Yay! We feel successful there. So I'm going to go through here, and I'm going to just point out the high points, but that's basically what chapter 38 says. I told y'all what heart failure was. Complex clinical syndrome that can result from a number of cardiac or metabolic disorders. It can be because of dead tissue in the heart. It can be caused because of severe hypertension, hyperthyroidism. A lot of things can lead to the heart's, can contribute to the heart's inability to pump. We have left ventricular dysfunction. And it is mostly, so ultimately one is going to lead to the other, because our heart pumps. If it's pumping normally, things are flowing from the right ventricle to the left ventricle, and the left ventricle is shooting it out to the body, right? Y'all remember that whole blood flow through the heart? So if we start with left ventricular failure, it's primarily characterized by that shortness of breath and that cough. But when our left ventricle is failing, very soon thereafter, our right ventricle begins to fail. And that leads to the edema. It's pushing all that fluid kind of back up. So the neck distension. So definitely think of them separately, but very frequently one leads to the other. Activation of the renin-angiotensin-aldosterone system occurs because of decreased perfusion to the kidneys. So if the heart is not pumping adequately, the kidneys are not receiving blood for filtration adequately. As the ROS system is activated, angiotensin II and aldosterone levels increase, which increases blood pressure, and that makes the heart work even harder. So everything is connected together. So you'll hear me as we go on talk a lot about my hospice patients. And there were certain ways that we knew that a patient's death was coming, because one thing, all of those body systems are so intricately reliant on one another that when one fails, another starts to fail, another starts to fail. So that's kind of what takes place. The heart is lacking, and then it's therefore affecting the kidneys, and then it's therefore affecting the blood pressure, and it's a whole vicious cycle, right? Neurohormonal activity in heart failure, increased secretions of epinephrine, norepinephrine result in arteriolar vasoconstriction, tachycardia, and myocardial contractility, resulting in a worsening of heart failure and reduced ability for the heart. So the heart starts working harder, but it's still not efficient. It starts beating faster, but it's still not able to get the blood where it needs to go. Here are the drugs that I previously discussed. Digoxin, Corlinor is a newer cardiotonic drug. When used with a beta blocker, it's shown to significantly reduce the repeated hospitalization associated with chronic heart failure. So this is the newer DIG, so to speak. It's the newest cardiotonic. Digoxin use continues for older clients. And that's the main reason. Is like I said, if it's not broken, don't fix it. If they've been taking it for 25 years, we're not just going to throw them on a new drug because a new drug came out. If their digoxin is working well, we're just going to roll with it. I already told you what it does. I already told you the side effects. Are y'all okay with me moving on? They are contraindicated in the presence of DIG toxicity. And in patients with ventricular failure and VTAC and AV block. All right, do you see these lots and lots and lots of drug-drug interactions? They can increase the risk for DIG toxicity. A whole bunch of medications can. So if you see digoxin combined with another medication, red flags ought to go off and say, ooh, I know this medication is very easily altered. You see those? That's more than we've seen with anything else, right? So some can increase the effects and some can decrease the effects. Thiazide diuretics we've learned about. Digoxin can increase the risk for electrolyte imbalances in those patients. Okay. For milrinone, that's found on page, it's a miscellaneous ionotropic drug. It's found on page 439. It is given IV. It's for management of severe heart failure. It's an emergency drug. Heart rate and blood pressure is continuously monitored. And if hypotension occurs, the drug is discontinued. And they must be on a continuous cardiac monitor for this medication.
Did you say that they're used in severe heart failure?
Severe heart failure, yes. And that's milrinone. It's usually given in the ICU setting. All right. So I feel pretty confident that y'all would be able to tell me what you're checking for these patients. Their blood pressure, their apical pulse. You're going to teach them to feel for their radial pulse before administration of these medications. What's the magic number? We're not giving patients DIG if their heart rate is less than what?
6.
Very good. We're going to listen to the lungs. Why are we listening to the lungs? Fluid overload. That we would hear some crackles because that fluid it's not being pumped adequately. It's building up. So we would expect to hear crackles in the lungs. Examining the extremities for edema. Checking the jug. You remember when y'all first learned with Miss Lott? Did y'all have Miss Lott last semester? And did y'all talk about JVD at all? Jugular vein distension? Does that ring a bell? Patients with heart failure often have that. So these are the patients that you'll see that in. We're going to measure their weight. That gives us an idea of how much fluid they're retaining. We're going to, if they're spitting stuff up, we want to know what their sputum looks like. We want to look for cyanosis. We want to see if their fingernails are blue. Are they short of breath? You know, those heart and lungs are very closely related. Because digoxin interacts with many, many medications, you have to take a careful drug history. Get all those meds that they're on. You must document the apical pulse, both the rate and the rhythm. We talked about this. We don't want it less than 60. We must weigh these patients. They may have imbalanced, as far as their diagnosis, imbalanced nutrition, because if they are having some dig toxicity, they might have anorexia, nausea, or vomiting. They might have some activity intolerance as related to their weakness and drowsiness because of that fluid overload. We want them to have an optimal response to therapy. We want them to be compliant. We want to check the orders. We want to make sure that when we're given these medications, we are checking those, we're giving it as prescribed. And if they've never had a digoxin level drawn, we want to be the person that's saying, hey, do we have one of these planned in the near future? So sometimes they'll get a higher dose. And so like they'll get a couple doses, but it won't reach that effective range. So they won't immediately get those levels drawn. You know, it depends on how these medications, they can be rapidly, they can get like a loading dose and kind of be at a therapeutic range, or they can be given a series of doses until it gets to that effective range. And that's per the prescribers. So if they are getting a high loading dose, if they're doing digitalization, the nurse is going to check their blood pressure, pulse, and respiratory rate every 2 to 4 hours. Because if we're giving it to them quick, we're going to expect that risk for toxicity to happen quicker. So we really need to be on it. Does that make sense to you guys? We're going to need periodic EKGs, electrolytes, hepatic and renal function tests. Cardiotonics can be given orally, IV, or IM. They're rough on the veins. So we want to, if we're giving it IV, you really want to monitor that site. We want to observe our patients for signs of digitalis toxicity. And then we just want to very carefully listen to our patients and monitor them and make sure that we are really astute to their changes in their physical assessment. So should there be any signs of toxicity, we're on it when it happens, not 2 days later. All right. And then, of course, we want the therapeutic effect to be achieved. And we want to identify adverse reactions. We want our patients to be compliant. That's really it. All right, true or false? Heart failure, sometimes called congestive heart failure, is a condition in which the heart cannot pump enough blood to meet the tissue needs of the body. True or false? True. The following statement, true or false? Right-sided or right ventricular dysfunction leads to pulmonary symptoms such as dyspnea and moist cough. No. Think left-sided lungs. Left-sided lungs. And is this following statement true or false? Cardiotonics increase the efficiency and improve the contraction of the heart muscle. Yes. I feel like cardiotonics are the easiest to understand. When a cardiotonic is used, the pulse rate is monitored. Which heart rate would the medication be held? A, B, C, or D? Yes, ma'am. All right, I'm done with that PowerPoint. That's the way to roll, huh?